Oh, hello there. I look like a potato. So now we get to switch gears and talk about the cardiovascular system, specifically dysrhythmias. So we're going to be talking about three specific dysrhythmias: AFib, VFib, and VTach. But because I like to make everything complicated, first I want to talk a little bit more about what exactly those things are by comparing it to a normal heart rhythm. Here we go. Look at that art. Wow. Amazing. So this is obviously an expanded little thing, but we can clearly see P, Q, R, S, T, U, V, W, X, Y, and Z. Just kidding, those aren't on there. But we can see the QRS complex, we can see the P wave. Now that T wave isn't always visible, but we can see that. And it's not important to know all of this shit, but essentially it's important to know what's happening generally speaking. So we have ventricular diastole happening here up until the complex reaches its point, and then we have it happening again here. So that's when the ventricles are filling up, and then eventually they will contract. And of course, because the heart is a two-pump system, we're having a release here, contraction here, and eventually we're going to have another release here, but there's another contraction in here. There's a lot going on. We also have a contraction here, a release here. That's not super important right now. It's just good to know just generally what's happening, at each point along the way, because we're going to see some very different things here in a moment. For example, we're going to see with AFib, we're not going to have the P wave. So that's fun. But just generally speaking, you can see the two-pump system here. When something is releasing here, something's contracting here, something's contracting here, releasing here, etc., etc. That's generally what we're talking about here. And it's important just to know, generally speaking, that there needs to be a certain electrical pattern here for that to happen, because we're going to see that disrupted in these specific dysrhythmias that I'm going to talk about, generally speaking. So, here we go. First up, we have AFib. Excuse my terrible art, and obviously it's not to scale, but what I was trying to show here is that we don't have a P wave. In fact, a much more accurate drawing would probably something like that. Like, clearly there's no specific P wave, but anyways, it's irregular. My drawing doesn't show it very well, but the space between the complexes is not going to be the same with AFib. Basically, what's happening is the atria are fibrillating. They're quivering. They're not contracting like they should normally. So we're going to have the normal QRS. You can see that. But there's not going to be a P wave, and it's going to be an irregular rhythm. Now, some labs you might want to monitor, some labs that could potentially lead to something like AFib. We want to look at thyroid function, liver function, kidney function. What kind of treatments are we going to have for AFib? We're going to have anticoagulants, antiplatelets. We're going to have pharmacological cardioversion with class 2 and 4 anti-dysrhythmia drugs. We could also come to electrical cardioversion if it's like really severe and if it's not responding to pharmacological treatment, or there could be an ablation. Next, we're going to talk about VFib, and it's a little bit more serious, but my artwork isn't. Basically, what we're having here, there's no P wave and there's no QRS complex, which makes sense if you think about it. Let's go back to my drawing on the other side. So if the ventricles are quivering, fibrillating, so to speak, that's what's allowing this to happen and this to happen. The whole filling up and contracting is what part of what we see causing this particular shape here. So if that's not happening, or if it's not happening in a reliable way, of course we're going to see basically just a bunch of waves. We're not going to see anything that resembles this, which is why you're not going to have a pulse. Anyway, going back to this, it's going to be irregular. It's one thing I can say is accurately depicted in my drawing here. It's going to be irregular. There's not going to be a P wave. There's not going to be a QRS. This is a shockable rhythm. In fact, you better shock, or yikes. There's not going to be a pulse, and the rate of the electrical stimuli, it's immeasurable. So don't get confused, because over here I'm going to mention there's no pulse and there's also a rate. That rate is referring to the contractions. There's no clear pulse. So anyways, going back to VFib, there's not going to be an audible heartbeat, there's not going to be a palpable pulse, and they're not going to be breathing. So that's not good. Clearly it's going to cause decreased cardiac output, ineffective tissue perfusion, because it's essentially not pumping. It's just fibrillating. It's not doing shit. So we're going to do CPR, we're going to defibrillate, and we're going to medicate with amiodarone and or epinephrine. And we're going to pray, because that ain't good, fam. And moving on to our other situation here. Now, I wanted to point out this arrow here. These complications, decreased cardiac output, ineffective tissue perfusion, applies to both VFib and VTAC. So here it is regular, if you want to call it that, but there's no pulse, so I don't know if it's really even worth noting. There's no P wave, and this upside down, well, it looks like a U, but I guess you could also see a V in there. That helps you remember it, but basically that's going to be happening pretty quickly, between 100 and 250 beats per minute. And we're going to see a wide QRS complex. Now, over here, there wasn't a complex. You can't make out anything out of that. But here, you could see that there is a QRS, technically. QRS, right? So, anywho, shockable rhythm again. We want to immediately defibrillate if they're pulseless. They're almost always pulseless. Now, it is possible that there could be a brief moment when they're awake, assuming they're actually in VTAC. You might want to check the monitor first and make sure, or check their leads and make sure it's not just an artifact. But they're almost always going to be unresponsive and pulseless, so guess what you get to do? We're going to defibrillate, we're going to do CPR. We're going to manage it with cardioversion and antiarrhythmics, medications. We might do anti-tachycardia meds. Just remember that, because tachycardia. You get it. And something called pacing, which I actually had a patient recently who was V-paced. Very interesting. And he sure had a steady heartbeat. We could also see ICD being used here, or a cath ablation. Now, VTAC is the rhythm that our beloved Professor Teresa Chang said that, well, first of all, make sure you check the patient first, make sure it's not an error. You'll know if they're in VTAC or not when you check on them. But she did say you might try smacking them on the back if they're awake still, and that might bounce them back into normal sinus, but probably not. Maybe. I don't know. She's been doing it for a long time. But essentially with VTAC, there's a little bit more of contraction of the ventricles, which is why they may not be unconscious right away. But it's not going to last. Eventually that perfusion will stop. They will lose consciousness. They will lose a pulse. They will stop breathing. So similar interventions with VFib and VTAC. Those are shockable rhythms. But nursing priorities for all of the dysrhythmias, we want to make sure that perfusion is happening, that oxygen is going into the body. We want to keep the body alive. Yeah, I had a patient one time who technically her heart restarted again after she lost consciousness and her heart had stopped, but her brain never recovered because it did not get perfusion, which is really sad. Really sad to think that someone did CPR on her and thought they brought her back, but she's pretty much brain dead, so really sad. Anyways, the point there is perfusion through the whole body. We want oxygen everywhere. for all of these dysrhythmias, whether it's VFib, AFib, VTach, we want to monitor the vital signs, blood pressure, heart rate, respirations in particular. I guess you could take the temperature, but I don't think that's really applicable here. So one less thing to worry about. We want to focus on reducing the patient's anxiety because as an anxious girly myself, I can confirm when I'm anxious, my heart rate goes up. So help them be calm, comfortable, assuming they're still alive. And we want to provide medication education. Whatever medications they end up on, they need to take them as prescribed, not stop taking them abruptly, not skip a dose, take them the same time every day. It is crucial. And if something's not working, if they're feeling short of breath, having palpitations, they need to let their provider know because they might need some other interventions. Complications we can expect to see from dysrhythmias, particularly those that aren't being managed well: thromboembolic events, strokes, that sort of thing. Once a patient's on anticoagulants, they do need to be monitored for bleeding, and I think they should still be assessed for signs of DVT, PE, that sort of thing. Also, we're going to see potentially heart failure and or hypertension. This puts a lot of strain on the heart, obviously. The heart is a muscle. It's going to get tired. It's going to work less well, and it could potentially cause cardiac arrest and or death. So, that's unsettling. That's all I got.